Good afternoon, everyone. We will be getting started in just a minute or two. We want to give a few minutes for people to join.
Hello, hi everyone, welcome.
Okay, I think we will get started. I know that there's a lot to cover today, and I want to make sure we take advantage of your time. So welcome to today's webinar. My name is Amy Rosenstein, and I'm the Administrative Director for MCPAP for Moms. And this is, excuse me, our quarterly MCPAP for Moms webinar. Today we'll be talking about an update on antidepressants. Our next webinar will be on Thursday, April 23rd, where we will be talking about validated screening instruments to use throughout the preconception, pregnancy, and postpartum phases. So please be on the lookout for an invitation about that session with more information when we get closer to that date. Before we get started, I wanted to give you a few housekeeping details. This session is being recorded and it will be available on the MCPAP for Moms website. We'll also be posting the PowerPoint slides from today's session on the website. You'll find it in the toolkit and resources page under PowerPoint presentations. Our presenter today will be stopping at different points to answer any questions that have come in through the chat, and then there'll be time for questions at the end as well. If you do have questions or comments, please enter them into the question box, and we will, again, make sure that we cover them either during the session or at the end, or you are also at the end welcome to unmute your line to ask your question directly. And then we're excited that this is the first time we will be offering CME for the webinar. So after the webinar, you will receive an email with a brief survey. If you're planning to claim CME, you are required to complete the survey. But we also are always very eager to get any feedback on our sessions and the topics you're interested in and any suggestions you have for us. So without further ado, let's get into the session. Today's presenter is Dr. Aruj Haider. She is the medical director of MCPAP for Moms, as well as the medical director of Women's Mental Health Clinical Services and an assistant professor of psychiatry and OBGYN at UMass Chan Medical School. And she is a consulting psychiatrist at Lifeline for Families. She enjoys giving state and national talks on perinatal psychiatry access programs and their impact, and also on important women's mental health clinical topics. Dr. Haider also serves as the medical student clerkship director for the Women's Mental Health Elective in the Department of Psychiatry and has received numerous awards in trainee education. Her particular clinical expertise is in caregiving support and sleep, perinatal OCD, and psychosis. So again, please use the question function to ask questions or click the raised hand button also if you would like to unmute your line. And so with that, I would like to turn it over to Dr. Haider.
Great, thank you, Amy. Hi, everyone. My name is Aruj Haider. Looking forward to being here with you all today and to discuss this very important topic, an update on SSRIs, antidepressants, and how MCPAP for Moms can help. I have no financial disclosures to report. All right, let's get started. So today our objectives will be how and when antidepressants can be used, and then we'll talk about the updated data on antidepressants and go through some of the research that we know, the recent research, and how MCPAP for Moms can help, and resources that we would like to discuss and share with you all today. Great. So maternal mental health affects mom, child, and family. And we know that untreated mental health can really take a big toll on the mom, the infant, the family unit, and even the social units, with that family. So it is certainly a preventable cause of maternal and infant mortality. And untreated mental health leads to a myriad of complications, less engagement in medical care, smoking and substance use in the mom while she's pregnant, when the mom has the baby, potentially preterm delivery, low birth weight, NICU admissions, and in the postpartum phase, lactation challenges, bonding issues, adverse partner relationships, cognitive delays, motor and growth issues, behavioral problems, mental health disorders, all in the developing child, infant, toddler. Next slide, please. So perinatal mental health and substance use disorders are common, undertreated, and the leading cause of maternal disease in the United States. So in the blue bold on the bottom, we see that mental health conditions are the underlying cause of 23% of maternal deaths in the US. And this is really important data. So the 2017 to 2019 Maternal Review Mortality Committee show that mental health conditions are almost 10% higher than any medical cause. And the highest was actually postpartum hemorrhage at 23%. And 23% of maternal deaths in the US are due to mental health conditions. And perinatal mental health and substance use disorders are clearly a leading cause of maternal mortality, driven by both suicide and unintentional overdose. And prior data, when they've gone back and looked at this data, 100% of them were shown to be preventable. So this is really important data I want to highlight with you all today. I'll also add that substance use disorder has historically been siloed from mental health, and this slide is an important reminder that mental health includes individuals with substance use disorder. And perinatal psychiatry access programs like MCPAP for Moms are really an important opportunity for substance use disorders to be integrated into perinatal mental health conditions. So on the left-hand side, we see that 1 in 5 women around the world will suffer from a maternal mental health complication. And on the right-hand side, the blue is treated women, which is 25%, and the red is 75% remain untreated. So what this pie graph shows that even if someone screens positive for depression, less than 25% of women actually get to an initial mental health appointment. Screening in general, it can be secondary to many different reasons, barriers in treatment, patients don't trust their physicians or the healthcare system, clinician shortages, limited resources, and these barriers can also be amplified by adverse social determinants of health. So optimizing perinatal mental health could really break that transgenerational impact of maternal depression. And frontline providers like you all really have a pivotal role here. Next slide, please. So perinatal depression is the most common complication of pregnancy. It affects as many as 1 in 7 women. And what we do know is the highest risk time for women for mental health disorders really revolves around childbearing. So for example, averaging across populations, 1 in 7 or 15% of pregnant and postpartum individuals experience perinatal depression. 1 in 5 women around the world will suffer from a maternal mental health complication. So in some populations, like socioeconomically disadvantaged populations, the rates can be as high as 30 to 40%. Now, does having perinatal depression mean you absolutely need to be on medications? No, it does not. And what we'll discuss is that there are non-psychotropic measures that we can always offer to our patients, like psychotherapy, diet, exercise, nutrition, and if those are not sufficient, then we can have the discussion about antidepressants. So throughout this presentation, I would encourage you all to remember that maternal mental health complications can affect any perinatal individual, a neighbor, a sister, a mother, a colleague, even ourselves at times. And there's always a story behind each person. So my goal with you all today is to really highlight best practices to implement changes that will hopefully help identify individuals so they can get needed help in an environment that really supports them and their families and their social unit. Next slide, please. So 2/3 of perinatal depression begins before birth. This study from Catherine Weisner is often cited. So the pink is during pregnancy, 33%. Yellow is before pregnancy. We see here 27%. Blue is postpartum, 40%. So what do these numbers actually mean? So this was actually the largest scale depression screening of postpartum women, and the first time a full psychiatric assessment had been done in a study of postpartum women who had recently screened positive for depression. The study, which included depression screening of over 10,000 women who had recently delivered, revealed a very large percentage of women who suffered recurrent episodes of major depression. So, what they found after this study is that 33% of perinatal depression really begins during pregnancy. So, that's the pink. 27% is before pregnancy. So, in summation, two-thirds of perinatal depression is really beginning before birth, before the baby is born. And only 40% occurs after the baby is born during the postpartum phase. So this directly translates to treatment because we want to connect at-risk individuals to mental health providers as early as possible, even during the family planning phase, since two-thirds of perinatal depression is really beginning before birth. Next slide, please. So I'm often asked, at MCPAP for Moms, we are often asked, are antidepressants, particularly SSRIs, safe or unsafe? Now, both providers and patients, we can stay on this slide for a second, thanks. Both providers and patients often wonder if they're safe or unsafe to the developing fetus. And the fact is, both the words safe or unsafe, in my opinion, are factually incorrect because I really believe the discussion should be about a risk analysis instead. So let's talk about this for a second. Next slide, please. So in this pyramid, before we discuss what a risk analysis looks like, I think it's important to understand how to properly analyze data and what that means. And this goes back to the basics of the scientific method. So the scientific method, what it is, it's a systematic process for understanding the natural world. And you can make an observation, you can ask a question, you test a hypothesis from that question, you conduct the experiment, you analyze the results, and then hopefully draw some sort of conclusion. And in many ways, I really think this slide is the most important slide of this presentation because it shows us that unfortunately one study, when we are asking a scientific question or we're just wondering about the natural world, it's not enough. Ideally, we want to duplicate and replicate the findings many different times by many different researchers, and we need many studies before drawing conclusions, and this takes time, and many different types of studies. So the scientific method, it allows us to really to question and at times be skeptical of the data, but we have to prove that skepticism with objective evidence. And prior to the scientific method, what humans did is they really relied on their intuition and their basic observation of the natural world. And the development of millions and millions studies over the past several hundred years is why life expectancy of humans has really drastically improved and why we have a better quality of life by treating disease and creating antibiotics and saving lives and targeting cancer. And we didn't always have these options because in the past, before before many different types of rigorous studies were created, sometimes these diseases would kill people. So I just want to give that frame before we talk about how this can be applied to antidepressants. So if we apply the concept of the scientific method to antidepressants and what kind of data we have on antidepressants, part of the answer really lies in the nature of the evidence. So randomized controlled trials, which you see in the middle of the pyramid in the light purple, they are the standard for establishing causality, and they're not applicable in the perinatal population for ethical reasons. Many, we can't intervene in pregnant individuals. It would not be ethical. So as a result, a lot of what we know about the risks from antidepressants and SSRIs during pregnancy, it comes from observational studies. And that in itself, it presents substantial challenges in terms of study design and how to actually interpret the results. But sometimes it's the best that we have and we can work with it. It also means that it may be difficult to separate the effects of the medication from the effects of the underlying illness. And you'll often hear me come back to that through this presentation. And I'll also add that We do have meta-analyses, which are more evidence-based than systematic reviews. And systematic reviews you see are on the very top. So, really high, like some of the highest quality of evidence that we have. And meta-analyses are very strong, and we have those on antidepressants in pregnancy. So that's good. It's rigorous. It's strong. It's evidence-based. It's objective. Next slide, please. So understanding the data, we must learn how to properly analyze the data. We have extensive observational data and meta-analyses, which are very rigorous and strong. We lack randomized trials in the perinatal population for ethical concerns. Data supports the risk of untreated illness. It outweighs the risk of side effects, of the minimal side effects of SSRIs, but that discussion, that risk analysis still needs to be had with our patients. So again, I'd encourage everyone to reframe it as a risk versus risk analysis instead of a risk versus benefit analysis. And we always should recommend psychotherapy and or medications. So again, I think the takeaway from this slide is calling antidepressants safe is misleading. While we have extensive observational data, we do lack the high quality randomized trials in pregnant individuals. Um, so in contrast, saying a medication is unsafe is also incorrect because long-standing scientific evidence, like I just discussed, indicates that the risk of untreated illness significantly outweighs the small risk of side effects of SSRI use during pregnancy. And this evidence is from decades and decades and decades, but we still need to discuss that with a patient and be fully transparent. Next slide, please. So risk versus risk analysis. No choice is completely free of risk. We need to balance and discuss the risks of medication treatment and risks of untreated illness. So the individualized, and I'm emphasizing the word individualized decision for an individual, a mom to take an SSRI during pregnancy is not a risk versus, it's not a true risk versus benefit analysis, but instead a risk analysis. And I'm emphasizing the word individualize here because as a perinatal psychiatrist and a prescriber, I am the first to acknowledge that medications may not be for everyone, and some patients may not want to take medications. And there are many patients who choose to go that route to not take antidepressants, and that's their decision, and we want to support them and work with them. And I think everyone on this call will agree with me when I say we always want to support our patients and their preferences first and the decision they choose after that the risk versus risk analysis has been had and the research has been discussed and what works best for the patient. So psychotherapy, diet, nutrition, exercise, they all remain evidence-based non-psychopharmacological measures that should always be encouraged. Now, since 5% of pregnant individuals in the United States are on SSRIs or use SSRIs, we must weigh the risk of untreated mental illness on the mom and the fetus with the risks of psychotropic exposure to mom and the fetus. And this is really that risk analysis, that I will continue to highlight during today's lecture. Next slide, please. So, maternal mental health affects mom, child, and family. And this is a repeat of the earlier slide. So what we see here in the blue are all the potential side effects from untreated mental health illness that can be potentially very treatable. Next slide, please. So risk versus risk analysis. Again, no decision is risk-free. So SSRIs remain the best studied class of medications in pregnancy. So we know that pregnancy in itself is not a risk-free state to be in. So it carries a baseline of 2 to 4% of a baseline risk of 2 to 4% of congenital malformations. It can be very anxiety provoking for a lot of moms and spouses and partners and husbands and families and everyone, they closely interact with because it's such an intimate and complicated time. It's also correlated, it can be correlated with interpersonal violence. It can contribute to rare conditions like postpartum psychosis via the sudden withdrawal of hormones like estrogen and progesterone in the postpartum phase. The list goes on. It's not a risk-free state. As a perinatal psychiatrist, I've recently treated an intensely sleep deprived mom who was in her postpartum phase. And upon learning that she had unexpectedly become pregnant, she stopped her antidepressants and she became convinced that something bad was really, really going to happen to her unborn baby. Her anxiety spiraled. She began missing prenatal appointments, unfortunately. And those appointments could have monitored fetal health. So after delivery, really driven by this untreated and intense anxiety, she became so fearful that she even hired two different newborn care specialists to watch her baby. And in addition to that, she set alarms throughout the night to really check on the baby. And it's interesting because the medication that she feared in the end potentially could have harmed her less than her untreated illness did. And so this patient went on to go back on her antidepressants, and it was a very positive story in the end. But I think it's a really interesting clinical case that highlights the importance of medications after that risk analysis is discussed with our patients. Next slide, please. So I'd like to emphasize evidence-based, non-psychopharmacological measures to treating perinatal mental health concerns. So we see here sunlight, exercise. So, we know when UVB rays in the atmosphere hit our skin, that goes to the whole vitamin D3, activation through cholesterol compounds. And some studies suggest that adequate vitamin D levels can really support mental health. And this is sometimes why we obtain vitamin D levels and why supplements can be offered. So, that's one intervention that we can do that doesn't have to do with medications. I think exercise and restorative uninterrupted sleep are so, so important for anyone, for all mental health conditions, especially if you're pregnant or postpartum or struggling. Just we feel better when we sleep. Um, I would say cognitive behavioral therapy, interpersonal therapy, behavioral activation, cognitive behavioral therapy for insomnia if one is struggling for sleep. These are all very evidence-based measures to help improve our mood. Mediterranean diet, there's good evidence for the Mediterranean diet and depression and making us feel better. I would say also social connection, intentional social connection. We as humans, we're social creatures. We thrive on being around others. And so intentional social connection that's low stress in nature to organize, and quality of social relationships, not quantity, can be very helpful. Light therapy has some good evidence base, well, omega-3s. Um, and then, of course, if any and all those don't work, then we can talk about medications if the patient is interested. Next slide, please. So I like this self-care plan from the Lifeline for Moms toolkit, and this is on the MCPAP for Moms website. It highlights different things that we can do, and this is whether or not the patient is on medication. So a lot of it is what I just discussed in the last slide. So belly breathing, um, I would say mindfulness-based cognitive therapy also has good evidence base, so that comes from that. Mindful breathing, uninterrupted sleep, making time for measurable activities, staying physically active, exercise is so important, asking for help when you need. So this self-care plan is available on our toolkits online. Next slide, please. So there is a high risk of relapse during pregnancy and women discontinuing antidepressants preconception. So now if our patient or a perinatal individual decides to take antidepressants, what does it look like if someone comes off of those antidepressants? So for individuals who make the decision to use antidepressants during pregnancy, they are likely doing so because they are at high risk for recurrent illness during pregnancy and the postpartum period. And so while SSRIs may carry some risk, discontinuing treatment proximate to delivery may place the individual at increased risk for relapse as she enters the postpartum period, which is the time of very high risk in individuals, especially if they have a history of depression. And so this study from Yonkers in about 2011 is often cited. And what it showed was that of those individuals who continued their antidepressant, they had a 26% chance of relapse and depressive symptoms versus those who discontinued. On the second line, you see they had a 68% chance of relapse. So I think the takeaway also from this study that I like to highlight is pregnancy is not protective. We often think that it is, but it's not protective with respect to the risk of relapse of major depression. And individual with histories of depression who are euthymic, who are stable in the context of this ongoing antidepressant treatment, they really should be aware of the association of relapse of depressive symptoms during pregnancy with antidepressant discontinuation. So I think that's an important takeaway. Next slide, please. So, same prescribing principles for preconception, pregnancy, and breastfeeding. So I would say this is for almost all psychotropics, but specifically for antidepressants. We want to use what has previously worked if the patient agrees to take an antidepressant. Um, After that risk analysis has been had, using the effective dose, the most minimum effective dose. We want to minimize switching. We always want to recommend monotherapy if preferable. Be aware of the need to adjust dose with advancing pregnancy if clinically indicated. We always want to discourage stopping SSRIs prior to delivery. At one point years ago, the recommendation was to consider stopping antidepressant, but there's a high risk of relapse postpartum, so we don't recommend that anymore. We want them to continue third trimester, day of delivery, postpartum. So a little bit of SSRIs and how they work. So antidepressants, including SSRIs, SNRIs, serotonin, noradrenaline reuptake inhibitors, they block the SERT transporter that we know within the membrane by binding to that central binding cavity that you see here in the pink in that transporter. And what that does, it prevents the reuptake of the neurotransmitter in the presynaptic cleft, and that increases the overall activity and availability of the serotonin in the synapse. So in theory, this is how SSRIs and SNRIs really reduce some of the symptoms of depression and other mood-related conditions. And the next slide goes into why exactly do they work. So serotonin is implicated in many mental health conditions. So the therapeutic actions of SSRIs and SNRIs, they really work by increasing that deficient serotonin in the human body. That's really what it comes down to. And that is the idea of the cause of depression in the monoamine hypothesis, which we call it. So unlike other classes of antidepressants, SSRIs have little effect on other neurotransmitters such as dopamine or norepinephrine. And SSRIs also have fewer side effects, comparatively speaking, than tricyclic TCAs and MAOIs because they have less effect on adrenergic, cholinergic, and histaminergic receptors. And that clinically, it makes a clinical difference in treatment because they can be potentially less sedating compared to other antidepressants on the perinatal individual and the developing fetus, the baby. Next slide, please. So now we'll go into the updated data on antidepressants and what that actually looks like. And MCPAP for moms, the consultants are often, asked, what is the recent evidence? So this is a great opportunity to review that with everyone. So most data does not support the increased risk of birth defects. So paroxetine and cardiovascular defects are often asked. So data is inconsistent for paroxetine, but not associated with increased risk of cardiovascular defects in larger studies. So there were large studies in United States and Europe that did not show a significant increased risk in birth defects in babies exposed to SSRIs during pregnancy. So paroxetine use during early pregnancy has always been the most controversial since it's always been associated with an increased risk of overall major malformations, particularly atrial and ventricular septal defects in several studies in the baby's heart. So I think the takeaway from this slide is in the first trimester up to 13 weeks is when the major organs in the baby are being formed. And so therefore, exposure to any teratogen is of concern. So since 50% of pregnancies in the United States are unplanned, and many women don't find out that they're pregnant until about halfway through the first trimester, paroxetine at McPap for Moms, we don't recommend it as a first choice for an SSRI unless there's a very clear clinical reason the patient needs to continue it. And that's something we could always discuss with you. So again, the findings are inconsistent and the absolute risk appears to be small, and meta-analyses overall are reassuring, but we don't recommend it as a first choice. There are other SSRIs that have much stronger data, which we'll get into. Next slide, please. So transient poor neonatal symptoms with exposure to antidepressants. So this is transient self-limited syndrome that may occur in up to 30%, 25 to 30% of neonates. Data does not support taper in the third trimester. So this is time limited. It goes away within days to weeks of the baby being born, and it is not harmful to the baby. Treatment is really focused on closely observing the baby, the newborn. I think the severity and length of this condition, it's really impacted by multiple factors, and the risk can increase with polypharmacy, particularly benzodiazepines, or the late introduction of antidepressants, particularly those with short half-lives. So it presents as irritability, abnormal crying, tremor, lethargy, decreased feeding at times, in rare cases, respiratory distress, but it is not harmful to the baby. And again, the doctors in the hospital will closely watch the newborn if they clinically suspect it as it resolves. Next slide, please. So persistent pulmonary hypertension, this is often asked too. So the absolute risk of persistent pulmonary hypertension appears to be very small. The baseline rate of PPHN is 1 to 2 per 1,000 births. This may increase to 2 to 6 in 1,000 births. So in the general population not exposed to any SSRI in pregnancy, the risk of persistent pulmonary hypertension is that 1 to 2 that you see on the bottom in the blue per 1,000 babies. In babies exposed to SSRI in pregnancy, that risk becomes 1 to 6 in 1,000. So that is less than a 1% increase in risk based on associations rather than proven causation. So the takeaway of this slide is that the risk of persistent pulmonary hypertension with late pregnancy, associated with late pregnancy exposure to antidepressants, if present, it's even smaller than previously reported. And most babies exposed to SSRIs, including paroxetine, they don't develop persistent pulmonary hypertension. And I think it's really important to remember that factors like prematurity, cesarean delivery, or even maternal smoking also contribute to persistent pulmonary hypertension risk, sometimes more than the actual medication itself. Next slide, please. So possible association with preterm labor and low birth weight. So depression is also a risk factor for preterm labor and low birth weight. And some studies suggest a small increase in these outcomes in those who take SSRIs. However, these problems are also more common in women with untreated depression. That is what the data has consistently shown. Limited studies do not suggest long-term neurobehavioral effects on children. So untreated perinatal depression in itself is associated with negative neurobehavioral effects on children. So, so recently there were high quality studies that were done which controlled for confounding factors such as maternal depression, genetics, and environment, and they did not show convincing evidence of a causal relationship between maternal SSRI use in utero and autism spectrum disorder in the developing child. The baseline risk of autism spectrum disorder in the general population is 1 to 2%. And if an SSRI is taken during pregnancy, that risk may appear to rise to around 2 to 3%. But after adjusting for confounders, that difference was not statistically significant. So the takeaway is even if a small risk exists, it's extremely small and far smaller than the risk of untreated maternal depression itself. And that came from recent very high quality studies, which you can see on this slide cited on the bottom. Next slide, please. So small absolute risk increase in postpartum hemorrhage secondary to SSRI use. It had a slightly increased relative risk of about 1 to 2. So SSRIs may be associated with a slightly increased relative risk of postpartum hemorrhage, about 1 to 2-fold, but many of these studies are observational. And therefore, there's always that risk of confounding with observational studies. So the absolute risk increase remains low. And I think that's important. So overall, it's unclear how much of that association is causal versus due to confounding. Next slide, please. Yeah. So now we'll talk a little bit about breastfeeding and antidepressants, and then we'll go into the program and how we can help. So breastfeeding generally should not preclude treatment with antidepressants. So SSRIs and most psychotropics are considered a reasonable option during pregnancy. Next slide, we go into some of the specifics. So sertraline, paroxetine, nortriptyline, and imipramine historically have the lowest passage into milk of the antidepressants. Prozac historically has had the highest, but I think the important thing to note is all have a low relative infant dose. RAD is how we abbreviate it, and they're all far below 10% of the maternal weight adjusted dose, which is what we look at. So I will add to this slide that changing from a medication that worked in pregnancy to a different medication in lactation is almost never a good idea, because if the patient is stable, there's really no clinical indication to change, since we know the antidepressants have such low RAD and transmission into the breast milk. Next slide, please. So antidepressants and perinatal substance use disorder. So we get questions about this. And what I will say about this is that SSRI antidepressants, they can help as part of MOUDs, co-occurring mental health conditions with the substance use disorder. And some evidence shows even post-acute withdrawal. So if you have a patient who, you know, has been diagnosed, or you're considering the diagnosis of some sort of substance use disorder, or they're under the influence of some sort, call us and we'd be happy to talk to you if an antidepressant would be appropriate to discuss, depending on other diagnoses or comorbidities. Okay, so how MCPAP for moms can help. So MCPAP for Moms was built off of the original MCPAP child program about 2 decades now, and it was really designed to provide a solution by building the capacity of perinatal care settings to provide mental health care. And our program functions through 3 main mechanisms. So first is resource and referral. Most of our phone calls are resources and referral. It's become a very popular usage of the program, and we have a wonderful team of many resource and referral specialists, and their expertise is really to tailor, vet, and apply the many perinatal resources and referrals that we have built across the state over the past 10 years, 11 years now since the program was created, and offer them to patients and sometimes to providers directly. So that's the first arm. We also have education. We can do webinars like this. We do trainings tailored to what you or your practice may need. We can also offer substance use disorder training, so that's always an option. And perinatal psychiatry consultation, our internal data has shown that the face-to-face assessments have really been the most effective in terms of offering treatment diagnosis to patients and providers. And so the perinatal psychiatry consultation has 2 arms. That's the phone consultation, where we would talk to providers directly and only. And then there's a one-time assessment, which is a face-to-face evaluation with patients. And if we feel after a phone consultation a face-to-face assessment would be needed, we can certainly arrange for that to happen. So since our launch in 2014, MCPAP for Moms has served many clinicians and parents. So we have 179 obstetric practices across the Commonwealth enrolled. We have 57.1% enrolled practices utilizing. We've served over 22,000 perinatal individuals distinctly, over almost 9,000 clinician telephone encounters. So that's the phone consultation I referred to in the last slide. We've had over 1,000 face-to-face evaluations. So our providers doing a diagnostic assessment, treatment, and plan with the patient while they're referring prescriber prescribes after that face-to-face evaluation. And we've had over 26,000 resource referral encounters. We serve about 300 to 400 individuals a month. So we have really enjoyed being a part of this journey with you all, and we're often asked who can call MCPAP for moms. And the answer here is anyone can call. While we only enroll obstetric practices, anyone can call. Primary care providers, pediatric providers, obstetric providers, midwives, family medicine, psychiatric providers, substance use disorder care providers, and doulas. So I'd like to share that as of February 2nd, we will now take calls from doulas as well. So if you have any questions, please feel free to call us and we can certainly help you with that. So that's an exciting development of the program. Next slide, please. So providers can call 855 Mom McPack, that's our phone number, for consultation for mental health and substance use disorder topics. So you will call, either get a live resource and referral specialist, or leave a voicemail. The resource and referral specialist will transcribe the voicemail, call you back with any clarifying clinical questions or demographics. And depending on the request, they will send resources directly to the provider and or do a provider to provider phone consultation. After that provider to provider phone consultation, which is with one of our psychiatric consultants and with you, the calling provider, there's potentially two things can happen: a face-to-face evaluation with one of our consultants and your patient if there's a clinical indication to do an assessment, or the resources can be sent to the patient directly, which would be called a patient contact. So oftentimes, in order for a patient contact to be done, we require that a phone consultation should be done. So I'll also add that patient consultations are for licensed independent prescribers. We don't prescribe for patients. This is not a patient-facing program. The goal of the patient consult is to help triage the patient and decide whether this is a patient you can manage with our help, and you can call back at any time if you had any questions about the patient or the medication, or if this is someone who needs to be seen by one of our psychiatric prescribers, or if it's unclear. But it seems that the patient is likely someone who, if it seems like the patient is likely someone who would be able to be managed by the primary care provider, we can definitely see the patient for one-time consultation. And if appropriate, we can also help out with care coordination after the patient consultation as well, which is what I was going into in the last slide. So the consultation is really the engine of MCPAP for moms. We discuss potential management strategies. We recommend a face-to-face evaluation. We refer to the community, and we've had over 22,000 encounters total to date. Next slide, please. So last, I'd like to go into resources, and then we can open it up for some Q&A. Okay, so research and referral is based on acuity, severity, and need. So there are two ways with which we offer research and referral. Either resources sent to the provider, and the most popular and common route is directly to the patient, where we outreach to the patient. So when resources are sent to the provider, and this is often where we predict doulas would be calling, where we can work with them and send them resources that they would then discuss with their patient. Our research and referral team would identify 2 to 3 targeted resources and share in a list form with the provider. So this does not involve speaking with a perinatal individual. And the second column, where patient contact, where we outreach to the patient directly, a research and referral specialist would contact perinatal individuals and work with them to schedule an appointment. And then they will also follow up with them after 1 month. And that appointment is really to discuss resource and referrals if needed. And our research and referral team really does a great job working with the patient, meeting them where they're at, and sending them and tailoring resources to their need. Next slide, please. So how can MCPAP for Moms help? So again, 855-666-6272, Monday to Friday, 9 to 5, to request any of the following resources, trainings, and toolkits. Our toolkits are in the process of being updated, and our updated obstetric provider toolkit and our substance use disorder toolkit will be on the website in the next couple of months. We also offer real-time provider-to-provider phone consultation and linkages with community-based resources. And so again, we aim to promote maternal and child health by building the capacity of frontline providers to address perinatal mental illness. And we have toolkits and e-modules that are available to obstetric clinicians through ACOG. So that's the link on the left. We also have our Lifeline for Moms perinatal mental health toolkit. And we also have e-modules that are owned by ACOG on the website, which we really encourage as a crash course for perinatal mental health. Great. And so before I go into substance use disorder, I believe there's a typo in the last slide. For resource and referral, follow up with the patient would be after 2 weeks, not 1 month. And so substance use disorder treatment provider toolkit. So MCPAP for Moms has a substance use disorder program dedicated to SUD concerns in the perinatal setting. So if you call the main MCPAP for Moms line and inquire about the program, our SUD program manager will get back to you. So the substance use disorder toolkit took several years to create. It was finished in 2021. It was just updated in 2026. Actually, it's being finalized now. It's available on our website. The updated one will be posted in a couple of months. You can have the full toolkit or as needed pages. It's a substance use disorder in the first half, followed by 3 fact sheets addressing non-stigmatizing language, trauma-informed care perspective, reproductive life planning in the SUD setting. And the second half is really focusing on psychiatric concerns. So the MCPAP for Moms SUD program, we're often asked about it. It's a sub-program of MCPAP for Moms that really supports providers treating perinatal individuals with substance use concerns. It offers consultations on initiating and maintaining medications for opioid use disorder, MOUD, other addiction treatments, managing dual diagnoses involving mental health and substance use. Our SUG program manager does a really great job connecting providers with resource and referrals across all levels of care. They can also offer trainings on key topics, including screening, treatment, trauma-informed care perspective for perinatal individuals with SUD. And we have the associate medical director of SUD can certainly talk about this with you if you're interested. And she and our program manager have really developed a lot of educational materials and toolkits to support you all with this. So feel free to call us with any questions about the SUD program. And I think that is it. A few updates, and then we'll open it up to Q&A. So doulas can call MCPAP for Moms beginning February 2nd. For perinatal individuals with SUD, we would like to share that it's exciting. Mass Health pays higher rates for peer recovery coaches and recovery support navigator services. So just wanted to share that with you all. I think that's a great recent resource. 1-866-705-2807 will have more information on that. Our future MCPAP for Moms 2026 webinars will be in April, July, and the one in October will focus on substance use disorder. And I think that is it. This is a list of vetted resources we encourage you all to look at. Screenshot, screen share will also be on the website after this webinar. Great. So I see a few questions in the chat. So let me just open up the chat.
Arush, do you want me to just read them off to you? Would that be easier for you? Or can you see
It's
them?
okay. I think, yeah, actually I can see them now. So that's fine. Thanks, Amy. Thank you. And this is such an important topic. Since last year, there has been confusion about animal studies and antidepressants in humans. Can you explain how animal studies could even help? That's a good question. So what I'll say about animal studies is I think in general, animal studies are useful for generating hypotheses. So I'm not discounting any research or any work ever done by a researcher on particular animal studies. But I think the fact is animal studies, they don't reliably translate to human pregnancies. So I think when we're talking about antidepressants, especially, and how that translates, there are obvious differences between animals, for example, rats, and between humans, particularly with drug metabolism, the structure of the placenta and how that was developing. Dosing is a big thing. And I would say, especially for SSRIs, the brain development and its timing, I think that's a big critical difference too. And behavioral outcomes, between animals and humans, there are obvious differences. But again, not to discount research that has been done on animal studies in any capacity. I think they're very helpful early on before we have human data, which we do, especially with meta-analyses being the strongest type of evidence that we have on antidepressants and maternal SSRI use in pregnancy and the developing fetus, and baby. It's a good question. How do you recommend us as providers framing a question about antidepressants when the patient still isn't sure if they want to take it? It can be hard when they're very depressed. That's a good question. I think that's always a challenge, especially when as clinicians or, any healthcare provider seeing the patient may be struggling or is depressed and they're hesitant. With my patients, I always frame it as I make recommendations, you make decisions. And I think that can be empowering because at the end of the day, it is a patient's decision to take a medication. And if she wants to take that after that risk versus risk analysis has been had, if she really wants to take that, there's still exposure to the fetus. We can't minimize that. The evidence is strong, but there is still exposure. And I think having that raw and honest risk versus risk analysis is so important. So if that's the case, I think there are other measures that could still be recommended, non-psychopharmacological measures like I had discussed, exercise, psychotherapy, great evidence for IPT and CBT and CBTI, and mindfulness-based therapy, diet, nutrition, restorative sleep, uninterrupted restorative sleep is a really big one. Yeah, so again, I always frame it as I make recommendations, you make decisions, and let's talk about it. And you may not be interested in taking the antidepressant now, but I'm here to support you. I'll keep following up with you regularly. And if you do change your mind in the future, I'm still here to help. And I think resources can be a really good adjunctive. So MCPAP for Moms, one of the reason our resource and referral arm of our program is so helpful is because really anyone and everyone can benefit from any type of resource. So a new psychiatric prescriber, the specific type of therapist, dyadic therapy, PSI, MMHLA, hotlines, help. There's so many tailored resources that we can offer, in addition to that. I know this is regarding SSRIs, but any resources to point towards mood stabilizers during pregnancy? Yes. So we have a lot of resources in our toolkit as well. Mood stabilizers and or atypical antipsychotics that have mood stabilizing function. We have treatment algorithms in our obstetric provider toolkit and our Lifeline for Moms perinatal mental health toolkit. The Lifeline for Moms toolkit is more comprehensive and longer, but the treatment algorithm for mood stabilizers and all psychotropic medications are actually in both toolkits. So I would definitely encourage you to check that out. And Beth will put the link for those in the chat as well, so you can quickly access that. But yeah, a lot of work has gone into that, so that's definitely available on our toolkits. And you could always call for a consultation if you had questions about specific types of mood stabilizers. Thank you all. Valuable update. Great. So can you discuss the use of zuranolone for postpartum depression and who is able to prescribe it, if it is available or accessible, example, covered by insurance? It's a great question. So zuranolone, so anyone can prescribe zuranolone. Any independent licensed prescriber across the country can prescribe zuranolone. It can and should always be covered by insurance. I had done a MCPAP for Moms zuranolone webinar, I think a year and a half ago, and I have a high level prescriber PowerPoint slide that is just like the 6 slides on the actual steps of how to prescribe zuranolone to a patient from beginning to end. And that is on our webinar link. So Beth, if you could also put that in the chat, that would be great. But those 6 slides go into who is able to prescribe it and the steps you do. With zuranolone, any type of insurance should cover it. And there's this kickback feature where if the patient has not received the zuranolone after it was prescribed or prescriber, I forget the exact number, the exact window, but I think it's a couple of days, couple of weeks max. It is automatically shipped to the patient's house. Remember, it cannot be sent to a retail pharmacy or a pharmacy with a physical footprint. It has to be mailed in. There's a specific way to do it, and I found Sage was very helpful. But the most important thing is being aware of the patient's insurance, getting in touch with the insurance to ask which mail order pharmacy it should be shipped to is the most important thing, and it saves so much time. So in that high level prescriber PowerPoint slide, it has the actual phone numbers for the uh, the commonly used insurances in the country, and you'd be able to navigate it on that. Um, Great. And zuranolone can be added on, I'll just say from a clinical perspective, to an antidepressant if the patient chooses to do so. Especially, I will offer it if if the patient is looking for a faster response, because it works as early as day 3. It's 50 milligrams every night for 14 days. You take it with a small fatty meal. But if you do prescribe it with an antidepressant, don't change the dose of the antidepressant. You want to keep it the same, because if the patient improves and the depression is better, you won't know if it was, the antidepressant in itself or the zuranolone. But again, that's also, we have some slides on that too. It's a good question. For the first time episode of postpartum depression and a patient who does not have a history of mental health disorder, what is your preferred med and dosing? Sertraline or fluoxetine, how to increase? It's a great question, and I think either of those are great. I'll tell you, so since you're specifically, Kristen, asking about sertraline or fluoxetine, sertraline can be sedating in my clinical experience in up to half of individuals anyone who takes it. So if a mom says to me, I'm having a lot of trouble sleeping at night, I'm going to think about sertraline, and if there's a component of OCD, fluvoxamine, and fluoxetine if there's less concern for sleep, and if they want something activating, I would recommend Prozac fluoxetine so they can take it in the morning, not at night, because if they take it at night, they will be up all night, and that won't be fun. So they'll take it in the morning, and that can be activating. So that's kind of how I go through both, but both strong evidence, very evidence-based. Sertraline has the lowest passage into breast milk. Fluoxetine has the highest, but they're still both very low. I echo the question regarding non-SSRI antidepressants and mood stabilizers, and if you have any resources available. Thank you for the great information. Sorry, I echo regarding non-SSRI and mood stabilizers resources. Yep. So I see Beth will email out those toolkits and the resources. Absolutely, we'd be happy to send that out to those who asked. Great. And we are at 12:58, so 2 minutes to spare. Thank you everyone for coming. I hope this was helpful, and it was great to see such fantastic questions. You're welcome.
And be sure, please, when you get the email with the survey link, please be sure to complete that. And then what I failed to mention before is that you will be receiving the CME certificate from UMass, who is accrediting this program. It'll come, there'll be a little bit of a lag time, but you will receive a CME certificate if you're an MD or an RN or DO. So we will make sure your name gets passed along. So thank you very much. And have a great afternoon. Oh, the in terms of access to the video or slides, those will be posted on our website. There will be a little bit of a lag. I believe we could send the slide deck out with our follow-up email, so you'll have that directly if you would like that.
Thank you, everybody.